The only time, please don't quote me, but it is a fact, the only time we did a TEE for him was when I begged him, because I was giving a talk on use of TEE in intervention, and I had to work hard on that. And I can remember only one serious hemopericardium that he had, that immediately he said, get me a needle. And he put the needle into the effusion. So I think at the end, if you're speaking about 20 cases a year, I think it's a very good number. But definitely there are people in this part of the world that are making much more than that a month. So let's share some cases with you about complications of mitral stenosis. And frankly, one of the most common ones we see is a persistent atrial septal defect. You've heard from Dr. Al-Kufi, it's 1.3 to 5, and definitely if they are big, the percentage is much less. But in the literature, that's a number, and most of the time they're easy to demonstrate, especially subcostally. And this is a gentleman, a lady who had mitral stenosis ballooned, and she remained with an atrial septal defect. When you look at it, size-wise, it was small, so it was no problem for her. You can even pick it with the Doppler. This is the second most common cause of complication, which is mitral regurgitation. And for those of you who don't see a lot of echo, the first thing you would notice that the direction of the MR and the site of the MR is not commissural. It's coming, if you just compare the 2D with the color, it's coming from the body of the leaflet, and not you don't only see it with the MR, you also see it with the inflow even better than the MR itself. You see now, you can see that the blood is passing from the left atrium in this area to the left ventricle in diastole through a break in the body of the leaflet. And if you look at it in short axis, you will notice that it is not a commissure which is split, it is the body of the leaflet itself which is split. And you can even see it nicely here. It's in the body of the leaflet itself that you have the mitral regurgitation. It is sometimes difficult to see the exact site for it, but definitely if you look hard, I have to tell you the truth, most of these cases are before the days of the 3D, but I'm sure with 3D it will be demonstrated much nicely. And if you look at this same patient at the two-chamber view, it's amazing how clearly it is that the regurgitation is occurring through the body of the leaflet and not at the commissure. But let me just show you the last case, which was a more complex case. I love hemodynamics when it comes to valve disease, especially when it is combined with other things. And this lady is an unlucky lady. She's now 68 years old, and she is in cardiac surgery intensive care for the last 6 days. She had mitral balloon in 2008. At that time, she had what was felt to be moderate TR. The interventionalist, of course, she had severe MS, but she also had moderate TR, and the interventionalist was hoping that this TR will decrease in severity after the balloon. Her pulmonary artery pressure was in the range of 45 millimeter Hg. She had her balloon, and the result of her balloon, remember, it is 2008 when 1 centimeter squared, this is with before the recent guidelines that say it's 1.5 severe. But this lady had 1.6 to 1.7, the result of her balloon. I would say it was okay, but not wow. because we've seen cases where above 2, 2.3, but at that time this was acceptable, and she was left with a good-sized ASD. Over the years, initially her pulmonary artery pressure started to decrease, but then started to increase, and I think related to the progress of her disease. Over the years, her TR increased in severity. You could ask yourself the question, why did she increase her TR? We know that she started with what was felt was a moderate TR, and it did not decrease significantly as expected, but you could also tell yourself, this is a good-sized ASD. Did it contribute to the size of the right ventricle, dilatation of the annulus, and maybe increase the severity of her TR? It's difficult to know, but it is worth thinking of. Surprisingly, when I was preparing this case, which has kept in my mind for a long time, she was my patient. TEE measurements were done one day, sometime in 2012, getting a ASD, pulmonary systemic shunt through a TEE, which I think was done at that time because before cardioversion, and it was measured as 1.5 to 1. And it was done beautifully, the RVOT, the LVOT, the diameters, and that was the number. So at least we have a vague idea about her shunt. In early 2019, she was symptomatic with moderate severe TR by echo, multiple admissions with congestive heart failure, mitral valve area of 1.6 centimeter, which has not decreased much, and chronic AF. Both ventricles were mildly to moderately impaired. She was discussed in a combined meeting between cardiologists and surgeons, and it was decided she is going to have robotic surgery on her mitral valve and her tricuspid valve. She had mitral valve replacement with a bioprosthesis and tricuspid valve repair with a 3D annuloplasty ring. The AST was also closed, and she got through her surgery on minimal support. So she did well initially through the surgery. Unfortunately, next day, she became very unstable hemodynamically, and she had recurrent ventricular tachycardia. An echo showed wall motion abnormality with good result of her surgery, and she had an urgent cath done with a rescue procedure. So let's look at her studies. This is early in 2019 when she became symptomatic, so she does have mitral stenosis, and she had a whiff of MR that you will appreciate later, very mild eccentric MR. You look at her TR, again, just to show the MR, it was very eccentric, but it did not extend too much, so she had the MS, and this will not play, but just to show you that she had MS and MR. That's her atrial septal defect. It was, I think, around 0.5 to 0.7 centimeter. This is the Doppler of it, and this is the color of it. Sorry, I don't know why this is not going to play, but this is just to show you her coronaries before the surgery, and they were normal. When she deteriorated, as I said, she had the cath, and again, this will not play, but luckily, I had a still frame that showed that her circumflex was occluded during the surgery. And I asked myself, I'm going to show you now her echoes immediately. She managed to get through her surgery with no problems, and she was on minimal support. And again, this is her TEE when she had the surgery. So she did have a good size atrial septal defect, which you could see by 2D and by color. This is just so you can think why her TR deteriorated. And this is the Doppler. And this is immediately post-operative of the OR. Her mitral valve was functioning okay, but again, for those of you who are even juniors doing transesophageal echo after every mitral valve replacement, look, do everything, but do again wall motion abnormality and look at the circumflex territory. And you can see that immediately after surgery, her ventricle was okay. There was no major problem with her ventricle, and I will tell you in a minute what the interventional person told me. So the contraction of the left ventricle immediately after surgery and maybe for 18 hours after surgery was okay. Look at it. It's not bad at all. And this is the next day after when she deteriorated, and you can clearly see that the circumflex was gone, and you can clearly see that this was gone. And when I spoke to the intervention, I couldn't understand why didn't it happen immediately. And he said that he felt from the catheter that the circumflex was not completely occluded as much as if it was pulled and narrowed by the pulling. And then he said, we saw a thrombus at that area. So my theory was maybe it was pulled and then the thrombus on top of this narrowing caused the problem. So by the way, the interventional person passed a wire easily across the narrowing. He put a stent, and at the end of the study, she had completely normal flow through her circumflex. So again, just to show you the wall motion abnormality, which resulted from compression or narrowing or whatever happens with sutures, putting a mitral bioprosthesis, and with the surgeon doing something with his suture. So complications do exist almost with all conditions, and the most common, again, I'm going to repeat, it is the interatrial septal defect, and some patients will have mitral regurgitation, but this has definitely decreased in severity. People are using now TEE, using 3D, they're blowing their balloons with more care, and thank you very much.
Thank you very much. Maybe the speakers can join us on the stage for some questions. Are there any questions from the audience? All clear? Any question?
Thank you, Maie, for this excellent case presentation. clear